Welcome to the MS Gym podcast, where we give you the tools to live life by design, not by diagnosis. I'm your host, Brooke Slick, and here we go. In this week's episode, I'll be sharing my interview with neurologist Dr. Bianca Weinstock-Guttman. She's a professor of neurology at Buffalo University, where her expertise regarding the Epstein Barr Virus, EBV, and her collaborative research as to how EBV relates to MS is extensive and impressive. This interview was originally recorded as part of the MS Gym's 2020 Virtual Thrive Summit, which I had the honor of hosting last summer. While the rest of the world was on lockdown, we were reaching out to experts to share their knowledge in the fields of anxiety, telemedicine, diet, and in this case, the EBV-MS connection. I found what Dr. Weinstock-Guttman had to say very intriguing, to say the least. So let's get started. Hello, everyone, and thank you so much for joining us today. We are going to be joined by Dr. Weinstock-Guttman, who is a professor of neurology at the University of Buffalo Jacobs School of Medical and Biomedical Sciences, where she directs the Jacobs Multiple Sclerosis Center for Treatment and Research. Her interests are aimed at identifying predictors of disease progression, with the primary focus on genetic and environmental interactions and influences on MS. In 2018, she was honored by the National MS Society with the Impact Award and was recognized for her work in pioneering new therapies and interventions to treat MS, as well as helping to develop a more nuanced understanding of the multiple ways that MS affects patients. And took a quote from that. It says, "It's the combination of her research, patient care, and advocacy skills that made Weinstock-Guttman so deserving of the award." So to say that I'm honored to have you on would be a total understatement. I'm so happy to have you here. I found you, I'll be honest, be very transparent about my past with the Epstein Barr Virus.
Oh.
I've been in the MS game for a long time. First symptom in 2001, diagnosed in 2006. But it's only over the last, say, 5 years, in all the background support groups for MS and throughout the MS community, I keep seeing the Epstein Barr Virus and its connection to MS come up. And I always kind of poo-pooed it. I was like, oh, another thing they're going to blame on MS on. And I just went on my merry way, never really read whatever anybody was linking to a group or whatever. I'd be like, oh, Epstein Barr again. It's not until recently when I was listening to a podcast interview and somebody said, well, Epstein Barr is at the root of trigeminal neuralgia. Well, I've suffered with it for the last 3 years, had 3 surgeries, and they said it's also the root of shingles. Well, it just so happens that every single time I had suffered from the trigeminal neuralgia attacks, I got shingles. So I started looking back through my medical records and I'm like, sure enough, every single time I had shingles. So then I started looking more into it and things just started making sense. So I thought, you know what, since we're going to have this summit, let's give the people what they want. Let's talk about the Epstein Barr virus and the connection. So I started researching and that's how I found you. And I was absolutely, I was hanging on every single word of all of your research and all of your papers. And I'm like, this makes total sense. This makes total sense. So I am here to get all the details about the connection between MS and the Epstein Barr virus.
Thank you very much. Yeah, we have a great team. And I'm really fortunate to work with a great team that are supporting all our interests. And I'm lucky.
How did you get, like, why Epstein Barr? Like, why were you drawn to that as part of your research?
So the Epstein Barr, actually you're looking on, I'm on this path with MS for almost 30 years. And looking over, I don't know if you actually saw back in the 1980s or something, the Epstein Barr was the first time, race that could be possibly related to MS. And after that actually fell. And that's because the number of patients affected by EBV, meaning when we're checking if the infection exists, MS patients initially were considered 90% and the rest of the population 80%. So because of very high incidence of infection on the general population, it was lost and reemerged maybe in early 90s with more and more, detailed assessments and understanding actually what EBV is doing as a virus, as part of the herpes family virus. But EBV is different. And as I said, the initial consideration that an EBV was taken away is because still the EBV is not sufficient for a patient to develop MS only through an infection. There are many other elements that may, connect with it, interfere with this, and that is the genetics, the vitamin D, all this environmental, the smoking, all this is what actually shown that may interfere with the way how the host, the person, is responding when is infecting to EBV. So it's not sufficient, but it's absolutely one of the triggers. So that is making so difficult to clearly saying that's what it is, that's the only thing. But I don't know if you saw the recent paper from GNP that came out from Germany that actually identified that even a very small number of patients were negative. They actually perform a much more sensitive measure and they were 100% positive. And they even put it on their conclusion that if a patient is diagnosed with MS and he doesn't have EBV, question the diagnosis.
Right. Question if they have MS at all.
Exactly.
Okay.
So that is it's very important. I think that we're learning even much more with the help of EBV how the immune system is responding, and eventually, hopefully, we can figure out much better how to prevent it and how to treat it.
And what exactly is the Epstein Barr virus? I guess we should have started with that.
So the Epstein Barr virus is a herpes virus. And the herpes viruses, we have also the viruses that provide the shingles, the viruses that produce, the CMV, the EBV, the other herpes the zoster viruses. So it's the viruses that this family of herpes viruses have. A different, type of developing. It's very difficult to provide a vaccine to it. Are changing a lot, and they are producing chronic infections. So the EBV also, as different type of virus, is actually infecting the B cells, and it was found that every time we're trying to look on B cells that are immortal, that are not dying, that is the way it's infecting with EBV. So the cells that are infected with EBV that are usually in the lab may become, as we're saying, immortal, that they live forever. But the virus is able to close himself into the cell and not to become active. So that is also often these viruses that it's also the viruses from hepatitis, chronic. So there are certain ways when these viruses can, encapsulate themselves, stay latent, and not to produce an active infections, but it's clearly changing the immune system.
So the EBV virus resides in the B cells.
Correct.
And it may or may not remain latent.
Correct.
Are there triggers? Have you witnessed triggers, something that can act like, what can bring on a reactivation of the Epstein Barr virus?
So often the reactivation of viruses can be related to any kind of decrease of the immune resistance. Okay. And could be another infection, could be stress.
Okay.
could be stress, really psychological stress, but could be stress, anything that maybe a surgery, maybe
A trauma?
a trauma, a severe trauma. So anything that affects the body
Right.
may actually, in a certain significant way, it may decrease all the immune system, and then it's waking up.
Okay.
And sure enough, everyone is different. There are certain people that are much more resistant and will never have really a severe, mounting of an infection or waking up the virus. But there are also consideration of the resistance of the immune system, meaning taking medications that decrease the immune system, even steroids
Right.
or another viral infection, or really the immunosuppressive therapy that we are using, cancer, treatment for cancer. All this can actually decrease the immune system that usually keeps the viruses contained, and suddenly they can really extend and take over.
So you're saying, because so many MS patients are on immunosuppressant drugs, it's during that time that EBV can be more active, or it's contained during that time?
No, meaning that depends. As I said, in general, the disease-modifying therapies do have, controlling the immune system and trying to balancing, especially the very early disease-modifying therapy that we calling them more, type of immunomodulatory and not immunosuppressive, that really kind of balancing between the suppression and the and controlling the infection. So they are really, in the immune system, it's a very, very important to be balanced, to be able, if there is an infection, to be able to control it, but in the same time to downside the overactive part that is happening in MS. So depends on the potency of the disease modifying therapy. As more potent the medication is actually may be associated with stronger immunosuppression. So, but in general, as we see also even with the potent medication, we don't have so many infection, but they are much higher than the medication that we see that are less potent, and we call it this immunomodulatory. So that is part
And
of
you're
it.
talking about rituximab, Ocrevus.
Exactly, after then the alemtuzumab. So, and that's different than the injectable, the Copaxone, the interferon.
Right.
Actually, the interferon has an even higher consideration of, because it's an antiviral. The
Mm-hmm.
problem on the EBV control is that the way how the virus, the EBV, is sitting into the B cell, that these B cells cannot be really benefiting from the interferon treatment. So they are kind of, closed in and somehow protected against the benefit of interferon. In the same time, eventually interferon can affect all the other viruses, because I said a viral infection can increase your immune system to fight on, and that can wake up it.
Right.
So if you control the rest of the infection with the interferon, it eventually can also protect us. There were, different studies and so on when we looked on the type of the effect of medication, and also on the disease activity, on the relation to EBV. In interferon treated patients, we couldn't see this, and that's because it probably does have a certain control on the rest, maybe not directly on the EBV levels
Right.
and so on, but you do have on the rest that, as you said, can increase the possibility of waking up the virus.
Do you attribute Ocrevus, and which is the rebranded rituximab, do you attribute its success to thwarting those B cells and
It's
therefore
possible.
thwarting EBV?
We didn't, the data is not yet there, and we're trying to see how can we actually monitor exactly what you're saying. So let's say 100% of patients with MS have the EBV.
Okay.
Now the question is, what is the ocrelizumab is doing, or all this anti-CD20 are doing? So they are, killing the B cells, a certain, type of the B cells, not the ones that at the end they produce the antibodies. But the question is really, are this effect only on the B cells that are only on the periphery? And that is very well known that it is. But the concern, what is coming up now and trying to figure out more, is actually the B cells that are already into the brain. We know that this kind of the pseudofollicles, the third type of lymphoid cells that are seen into the brain, in the subarachnoid area. So we know that this kind of pseudofollicles do have EBV inside it. And that is one of the consideration that may be related to the chronicity of the disease. You have their pockets of the EBV, or actually these B cells that can wake up and actually not only so, but has activated the cells around it, that the microglia, the astroglia, that may become, chronically inflamed, that and further on bring to the progression of the disease and the chronicity of the disease. So the question is, are these medications, the B cells that we're using now, able to control not only the B cells from periphery, but also have an effect on the B cells that are already into the brain? So that is the consideration. And the stages, because we know that the pseudofollicles of the B cells that are in the brain, actually in the PI area, subdural, they are increasing in number with the disease duration.
As the disease progresses, they're
That's
increasing.
Right.
Okay. Now, tell me about how Epstein Barr evolves or can evolve to become mononucleosis. And do people who have been diagnosed with mono in the past, are they more likely to ultimately move on to having MS?
So the issue is that the infection can be, with EBV, can be at different ages. Generally, it's during the childhood, and no one knows the infection is going on, meaning the immune system is strong enough to control the disease, control the infection. The virus is coming, you are in contact with the virus, but the virus after that is contained. And the only way to know that the virus was there, or is there actually, because I said there remains there, is to see that you have antibodies. But it's not, they didn't provide any kind of clinical symptoms, or very mild, upper respiratory, and no one knows. However, what happened with mononucleosis, usually coming in adolescents, is related to a delayed infection. So we consider this, and this is also a consideration on the theory of hygiene hypothesis. We're keeping our kids too clean and not exposed to environment, and therefore they are not in contact with EBV. Infection with EBV, as I said, in adolescents, if they were not before, it's very, very strong. And then you have this mononucleosis with lymph nodes swollen and fever and so on. And that is only suggesting that the EBV contact with the immune system at this stage is a very hard. And the response from it's changing in a so way the immune system and the way how the B cells are responding, and the B cells and the T cells, that because it's not only the B cells, it's a lot of the relation between the B cells and the T cells. The ones that are really destroying there are the specific T cells, the CD8 T cells. So the problem is that these T cells may not, see the EBV within the B cells. So, but it's also this storm that comes up at this age with the immune system that's already stronger than in childhood. And all the modification to it is actually suggesting that only is putting on together the base for developing MS, because they are modifying the immune cells in the same direction to a higher risk for developing MS.
Okay.
So it's primary, as I said, age-related, and it's the interaction between the immune system age and the late exposure to EBV.
Okay.
Having mononucleosis is increasing the risk to MS 2 times, up to 3 times. You also see that this is mostly seen also mononucleosis much higher in the area that we have MS.
Right.
And also in more industrialized and more developed countries where we keep our kids
Clean.
too clean.
Isn't that something? That's, I've heard that before. I've talked to my mom about that before. And to hear it in this context,
You say, why did you keep me so clean?
right, exactly. And this is a quote from one of your papers. It says, recurring clinical relapses can be associated with inadequate control of EBV reactivations. What are your thoughts on that?
So, as I said, in general, if the EBV is reactivating, sometimes the best way to evaluate is the shedding of the EBV, for example, saliva and so on, because they're sitting on your tonsils and so on. But we don't do so much on it, and there's also for short time. So most of the time when we're measuring is actually the antibodies to the virus. And we can try to identify, certain type of antibody. There are many antibodies, but there are early antibodies and late antibodies based on the reactivation. So we can try to figure out based on this if we have a reactivation of the virus now or in general, because most of the study that we did, and many of them were cross-sectional, is that we're measuring the level of the antibodies. MS patients even do have much higher antibody levels than the healthy controls. So if you're looking on the way how the immune system in MS patient responding to infection is different than the way how the healthy controls are responding to infection. So that is where everything is started. Now, if we have, it was identified that is eventually increasing in a level of viruses could be seen also during or preceding the acute events. That could be, but there were not many studies during this. So mostly what we looked on is that presence of active enhancing lesions.
Right.
And the studies, so most of our studies that looked on this was also on the data we have from a Czech Republic study that had all the patients with the first initial event of CIS treated with interferon. So the problem over there is that they were treated with interferon.
Yeah.
So we didn't see so much correlation with the active enhancing lesion. We seeing this with much more with the CMV levels. But it's clearly showing that, an infection. And often, as I said, if they did check, we didn't check any, as I said, EBV presence of the PCR, what we call in the shedding, preceding or before the infection, that it would be much more specific. But we monitoring the different type of antibody, we can determine that indeed there is certain changes and reactivation of the virus. But most of our data is really based on measurements on the level of antibodies. And we do see that the higher level were associated with more active disease. But mostly, as I said, because we have most of our data on cross-sectional, on patients that are evaluated, chronic, we do see actually atrophy and loss of tissue. That usually is a process that is actually more delayed from the time of the acute inflammatory process. As the inflammatory process is more severe, in a longer time, within 6 months, 1 year or more, you will see much more, tissue loss. So that is mostly what we identified in most of our studies, is including the clinical isolated syndromes initial study from Czech Republic on interferon, that with a higher level of antibodies to virus, or VCA mostly, that is more chronic, we saw much more atrophy of the thalamus is the first one, and also of the total brain volume. So the correlation between the disease activity, the inflammatory process, and longer time after then loss of tissue, it's very, very important. And now we learning more and more on how to correlate. And there is a little bit, not a perfect connection between, especially if we're doing something, and what is now tried in different studies, is between the inflammatory process and the loss of tissue within 1 or 2 years. May not see a perfect correlation. In a longer time, we do see that it's more inflamed, and if it's not controlled in 2 years, or you'll see much more tissue loss. And that is primarily related to limited physical disability, but also cognitive issues.
Do you ever think we'll see a day when, because I know it, let's say I've had MS for 5 years and I start having relapses. Anytime I had relapses in the past, the first thing they go to is the MRI. And sometimes they correlate, new symptoms correlate with new lesions, sometimes not at all. Do you think there will ever be a time when they say, just as part of regular practice, well, let's check let's check on their EBV, let's see if it's reactivated? And if they did,
that is the interesting. That's exactly. It's only a response to, as you see when you have, the issue what you said, when you have your trigeminal neuralgia, you do have a zoster infection, right?
Yeah.
So it's all to. When do you have usually a zoster infection? When your immune system is going down. What was the trigger first one? You were stressed, you had other things that we never know. Right. And that is actually, and also we have to, you're young, but that is another issue that we can discuss further, and there's a lot, and we are very much involved on it, is actually the aging population. Aging population has a decrease in immune resistance. And it's this term of immunosenescence. Now, unfortunately or fortunately, we don't have a perfect correlation between the biological to chronological age. But this is a fact. With the time go on and aging, there is an immune suppression. This is why aging population have a higher risk of zoster infection.
Right, shingles and
so on. So that is the issue is, so then it's all the time, but in the same time, they have a less risk for relapses or new lesions. But if it happens, the repair processes are less efficient because the production of the myelin from the oligodendrocytes and repair are less. So we have an in and out. So it's not only one process. So with the time go on, as I said, if there is any kind of factor that decrease your immune resistance, EBV can go up, but the question, what was it? You may have maybe urinary tract infection before.
Right.
Or that's starting on. So it's very difficult and it's much more complex. It's not only one event. This will come up, as I said, because all the immune system is kind of dysregulated. Something happened, and again, it could be even only a stress.
The balance is off.
That's correct. And then anyone that was sleeping, now it's waking up. So that it's only an indicator. Now, would we, as you said, maybe saying have a factor, looking on, keep going and have the viruses, the antibody levels, and suddenly we see jump on, that's it. And you may have said, this is indicating that the EBV is waking up, and I don't need to do an MRI. I know that this will be an issue. It could be. And this is what we're trying all the time to find what we're calling biomarkers. And probably you heard about the serum neurofilaments that now on, and everyone is trying to figure out a more sensitive measure of active disease without the MRI.
Right. So is there a treatment for EBV? What if I had EBV and I didn't have MS and
yeah. So there's no treatment.
There's no
treatment for EBV, and there's no treatment, and the consideration much more towards maybe vaccination, because each time actually when we're doing certain assessments, and what we're doing a lot, it's only what we're calling an association. We don't have a clear-cut support that what we found, it's measuring something with measuring other one, and other than correlated, is actually calling causality. Is it causing? So it's not there. However, the very important study that was done by Boston, I think a few years ago, probably you saw this, is that especially looking on the mononucleosis or EBV infection as relation to MS, that was most strongest, that this was done using the serum from the military enrollees, and they are, anyone that is going in the military, they have blood tests at the entry and every 6 months.
Mm-hmm.
And what they found is actually that they found 10 patients that they found out retrospectively, but went into their serum and so on, they developed MS. So all these patients, they looked on the patient that developed MS, they were negative at entry. They became positive after, and after they developed MS. So after then they looked on the same people, this another group, similar in age and so on, that were also negative, and after then became positive, but they did not develop MS. So that you have both. And the patient that developed MS, all of them became positive before developing MS. And the time between the being negative, and they had blood tests every 6 months, they become the risk to develop MS was between a year. There were 2 years, and there was one patient even after 10 years. So there is a lot of interference, and the immune system changes, but that's clearly showing that in order to have MS, you had to have become ABV positive.
Okay.
Now, sure enough, and as you said, the mononucleosis, that meaning this patient, when they're going to the army, they're 18 and above. So they never saw EBV before 18. That is very unusual. So they were not exposed to EBV in childhood, as we said before, it usually happened. And they had it after, and part of them had mononucleosis, part of them, they didn't have the mononucleosis. So they didn't have any symptom of the infection. So what they're trying now they tried before to try to see if they can do a vaccination in adolescents that are still negative. So the study, it was very limited. They did a certain type of vaccine. As I said, it's very difficult to do vaccine for herpes viruses because they are changing all the time. But they did certain against the capsules of the EBV. And what they found that actually they were able to postpone, there were, I think, 8 cases of mononucleosis versus 11 on not, vaccinated. It's very small differences, but actually they were not able to prevent the EBV infection. So the subclinical EBV didn't have any difference. Okay. They were able to prevent only the mononucleosis, that it's not sufficient to consider that this can be really a treatment for preventing MS. There are a lot of other considerations besides the vaccination, and there are, I think it's actually an ongoing study and so on. There were initial study with a few patients enrolled in, giving actually specific T cells, the CD8 T cells specific for EBV. That could be actually a good treatment. They used it for a secondary progressive actually, and patient did very well. So that is the consideration even on how to control the EBV. You need to have the specific T cells that recognize the EBV, and they are able actually to interfere and destroy the virus that in generally it's very well, hidden in the B cells. So that's is actually the one of the problems to develop T cells that are able sufficiently to recognize the EBV, even in the cells that are, keeping the B cells, hidden. Uh, in the same time, if the EBV is a very, very long time into it, this cells initially actually, it was found that the number of these specific cells with no treatment in MS, it's going up. They're trying to control it. And maybe this is why we don't have this EBV all the time, developing, because we do have, certain cells that can keep the control. And these are the T cells, the CD8 T cells. But with the time go on, and that is also going back on my now new baby, the aging, these cells are becoming tired. They are overworked. The same is for the CMV and for the EBV. And that's actually, again, the CMV is less, involved and less known about, but the CMV also, herpes virus, and the connection of both of them may have actually more to do than EBV alone. And the immune cells, they are trying to, for a long time, to keep this under control. With aging, with the immunosenescence, they are becoming tired. They are not able to support this control.
I see.
So we have a lot of cells that are able to control. This is why we need a healthy immune system.
Mm-hmm.
And any kind of intervention is also, the question is, how is this intervention given once, given twice, and after then give it the rest of the immune system to try to build back? That is also things that we are considering. Are we using only a milder medication continuously? Are we using a stronger medication, only unblasted, and after then waited for the rest of the immune system to recover? If it's, the same with the alemtuzumab, even ocrelizumab every 6 months and so on. So it's a lot of knowledge that we still have to figure out. And again, the immune system is not similar with everyone, and is also not similar in the same person with aging.
Right.
So that is so difficult to have one fits all.
So let me just play devil's advocate here. Let's
Mm-hmm.
say the Epstein Barr virus didn't exist at all.
Oh, that's a
What
kind of a sign to
what percentage of how many less people would ultimately develop MS? Because I know you said that it's not just EBV, that there are different factors, cofactors that can lead to developing MS.
I don't think that that could be considered if the EBV would be something else. Meaning, I think that as I said, when we're thinking now that actually 90% of the healthy population are also having EBV and they don't have anything, we can say that this is the problem, mostly. Meaning it clearly a very important factor that modify already prone an immune system. So the immune system in MS patients, it's maybe different. It's not decreased, and that is very important also to keep in mind, is that never and absolutely discuss with my patient, never go on supplements or something that will increase your immune system.
Right. And I think a lot of people do. They're like, oh, I've got to gear up my immune system.
Exactly. It's actually the opposite. So
right.
The immune system in MS patients are not, it's good and healthy. Actually, they are working too much in the wrong direction.
Right.
So if you boost your immune system in a certain way, they actually may have concern on reactivation of this, sleeping bad guys, that on the general, status, the rest of the good immune system is able to contain. But if you start to have anything else that is boosting the immune system and so on, you may have actually a wrong consideration. And that is, different. In one side, it can be over considered. For example, I'm thinking about zinc. Zinc is actually one everyone is taking on when they have a flu or a cold, right? Because it is boosting the immune system.
Yes.
It is a concern to take too much zinc in the long term, because that may over reactivate for a short time. If you have an infection or something, you can do. So I'm talking only a very small one, element, but there are many of them. You can see that they can really ginger, whatever other things that are considered healthy and so on. The question is, if it is considered boosting the immune system, if you're taking long time, if you're taking only, period, very short time, when you see that your immune system is down, that is something else. So that is also, I do very much support, supplements and so on. I'm much more towards good food and healthy food, but the ones that are very important is really the vitamin D and the vitamin B12 and the folic acid. So that's are the ones that really we need to be sure that we maintain in the good level. The rest, it's better to get all the supplements from good food.
So you said B12, vitamin D, and folic acid.
Yeah.
Okay. Interesting. Of course, vitamin D is always out there, but I know, and this was probably over 10 years ago, I asked my PCP if I could get a B12 booster shot or something. My mother got them when I was young all the time. And I thought, let me just try this. Well, I am telling you, I got that thing and my symptoms went through the roof. And it's not like a pill that just gets out of your system right away. It was like in there for a while. So it was going to linger for a while. So I never had a B12 shot again. However, now, and I've since, which I didn't tell you, I had a stem cell transplant 7 years ago for I had it done in Moscow. I've had no progression since. But I can still, there are even certain foods that I can eat where my fingers will get more numb than usual, or my foot drop will get worse. But I want to retry B12 now that I'm at a different point in my disease. Like I want to see, I want to test it.
Meaning the B12, it's and all in general the Bs are very important, and the B12 is primarily also involved in myelination, and it's the question is how much you're taking and how much this is it's used. It could be only symptoms related and relation to connect with really the repair. It's more difficult because it takes a longer time. But many of our patients have B12 deficiency when we check it out. And
so that might be a good place to start, is to have your doctor
check the B12. Even on the on all the labs now, they have still maintained the norm between 200 and 1,000, and actually everyone indicating that you have to have above 400. Even if the level are left at the 200, you have to be above 400. So even if we have 250, 300, we are adding on the B12 for our patients. Yeah, but that the same for vitamin D.
Right.
Before, everyone needs a different dosages. So I never recommend a specific, one fits all. It's only based on
your baseline.
On the baseline, yeah. So even on vitamin D, we actually also published this, and we saw this is not again 100%. But a patient with a good cholesterol, with a good HDL cholesterol, they don't need so much vitamin D. Their levels are much higher. We also found that the patient taking the statins, the lowering cholesterol, they will also increase their vitamin D. So it has to be checked and set the level based on what you have. Because now came out those studies with vitamin D too much, people having bone loss,
Right.
and and you have also the B12 if it's too high, and you have kidney problems, you have again problems. So nothing is too much is not good.
It's all a balance.
That's correct. Now, another study that I was talking about that was recently we published this is actually with teriflunomide. Teriflunomide does have certain antiviral effect. And what we found is actually that a certain patient with on treatment with teriflunomide actually had a decrease their EBV antibodies, and we saw actually correlation between preventing. We had this follow-up study on these patients that had less atrophy, and the patient that had less atrophy were the one that actually had a decrease in EBV level of virus.
And what is terafluoride?
Aubagio. This is one of the.
Okay, I was going to say, what's the brand name? So it's Aubagio.
Yes. So that is EBV was meaning Aubagio was showing also having a certain antiviral, and in lab for the EBV we showed that, as I said, decreasing the level of antibodies. Aubagio also showed actually benefit on patients with the family members, the same as PML. The JC virus is the
Yes.
BK virus. So it had the really benefit on the BK virus. So it does have certain antiviral benefits, and that is why we checked on this too.
So would Aubagio be a standalone treatment or a complement to whatever disease modifying?
No, Aubagio is a medication for MS.
So so it's a standalone.
Yep.
Okay, and that's how it acts. Like that's how it functions.
Yeah, no, it's it's working on a certain enzyme that and decreasing the division and proliferation of the activated cells. It's a different one. It's Aubagio is a teriflunomide. It's actually the active metabolite of the leflunomide that is actually a rheumatology. It was called Arava leflunomide for many years. So it's an anti-inflammatory product. So as I said, it's very similar with the leflunomide, the active metabolite that was used for rheumatoid arthritis, and it's used for rheumatoid arthritis.
So do you have patients that you treat with Aubagio?
Oh yeah, sure. Meaning we don't use only one medication. Yeah, the only more the Aubagio is approved 8 years ago. It's as compared with the other medications, it's not clearly suppressive. It's kind of the first line therapy.
Okay.
Actually now in comparison, for example, the ofatumumab, the newer one, it was compared with teriflunomide, and it is 50% stronger on the very active patients. So, again, it's a good medication. Usually, we're a little bit more concerned on pregnancy. So usually, I'm not using it for very young people, although we're expecting to have the results of using teriflunomide in kids. In children, we have, we do have 4 or 5% of patients having their initial onset before age 18.
Right.
So in this pediatric MS, and we're using everything that we use in adults, but really the only study that was head-to-head study was with Gilenya, with the fingolimod versus the Avonex, and showing actually, increased benefit versus the injectable. So the teriflunomide is the second one that we're waiting on the results. The study was completed for kids, and that was a different design, and that was against placebo.
Okay. Moving forward with your research, with whether you're personally involved with it or what's going on in the MS world, what would you like to see in the way of MS research? Epstein Barr Virus related or not? Like, would you like to see people digging further into Epstein Barr? What would you like to see right now in MS?
The consideration today is really first, in one side, to initiated therapy early on, and that is what they're pushing on. But in the same time, it's we have to, and there are studies going on trying to really prove or disprove that starting with a much stronger medication earlier on is better than later, because you're protecting better. But again, at the same time, we never know about the changing on the immune system, the risk for any viruses infection and so on, and the
Side effects, like long-term side
so
effects.
it's a long-term effect we do not know, but we're getting more, and that is in the end evaluating the patient from the beginning and try to identify factors that are associated maybe with more benign disease versus not. And I think that is very important before we going on one fits all. And in the same patient, you can figure out in the beginning what is the status, but this can change. And this can change with the hormonal changes, with the age. So it's not only the beginning, we know that maybe 15% of patients are very, very active. The rest is in between, and we have around 20% that are benign. They may not even need medication, maybe.
Right.
But we don't have a handle on it. So this is why we recommend treatment for all our patients from the beginning, now that we're able to diagnose so early on. Sure enough, if we have a patient coming up on their 50s with having tingling 20 years ago and now they have minimal spots and they are perfect, the question is now at their 60s or upper 50s, do they need really to have a very strong medication when they were able to control so good for so many years? So in one side, we have to learn much more about how the immune system is working, changing, and this is why we need biomarkers. And that's, I think, that we have to learn and to obtain different testing, blood, brain, MRI, anything else that can tell us what is going on for this specific patient, to be easy to administer, to be reliable, to be sure that if we have a change, we have to intervene. And now it's the one that is really the most up there is this kind of a serum neurofilament. There may be another one that is the GFAP, so indicator of inflammation, but they are not specific for MS. Yeah, it's going up also with aging. It's going up for trauma, so it's not specific, but it's something suggesting there's something going on. So the question is when we will have this, if we'll have possible. I do believe that will be helpful. I won't be able to, figure out clear cut that, as you said, you may see this going up and maybe we won't see the MRI because it's so.
So you'd like to see more sensitive testing.
That's correct. More sensitive, but clearly proven that the changes, because you may change 1 or 2 units, that doesn't matter. So we have to develop biomarkers, and that's also including MRIs and blood and so on. But we have also to determine what is the clinical or meaningful change. That could be only a lab change, simply they're doing the same sample and the second time you may have 2 or 3 units difference. That shouldn't be considered that you have a 3 unit difference, let's change the medication. So that is very, very important before all this. This is why it takes so long time before something is saying, this above, as we have other testing, when you're measuring different things, this is not good. That is clearly an abnormal. So that is all the developing biomarkers or any kind of measure are very, very important, and along with the treatments before and the research, and we are very much trying to involve on this, is to how to measure from a clinical standpoint, biomarkers and so on, that are very, very important to be sure that if we have a change, we can be sure that this change on this element is important. We have to do a change. Or we have to start from the beginning with more aggressive medication, or helping us much more in treating the individual and not kind of a general one fits all.
What are you currently working on anything, or are you personally looking to?
So yeah, we are working now. As I said, I had a very, and I'm still interested in pediatric MS. But now, along with my age and my patients that are aging, I'm very interested on it. So we're doing a lot on the cognition, try to differentiate the cognition between MS versus the cognitive changes with all aging. And we're looking also on the biomarkers, as I said, on these serum neurofilaments that are, we're trying to determine what are the norms for aging. And they're very much because now it's a lot of push towards that an aging population, they shouldn't treat with medication we have today. That we don't have a clear-cut information on it. Only yesterday I had a patient on her 58 with 3 new lesions on the brainstem. So it's not possible to saying you're 60, stop the medication. I'm not.
Right.
And there
Right.
is ongoing data on this, and we are really working a lot on it on patients over 55 and over 60, on aging, on everything, on MRIs changes, on cognition, on biomarkers. So and any kind of rehabilitation factors, dietary intervention. We are very much on wellness towards this, and hope that we'll have something
Well,
good
I am going to be
to
watching
offer.
you. I'm going to be checking back in and Googling for your name and your papers, because I was mesmerized by all of your work, just kind of hanging on every word as I read them, because they make you think more about the disease you're living with. Certain things, you start putting all the pieces together and you have a couple of aha moments, and you're like, wow, okay, that makes sense. So I appreciate that you're out there every day trying to do everything you can for the MS community and your patients. And I cannot thank you enough for having come on.
Sure, thank you very much for, and it's only kind of this feedback that makes me going.
No, it's important. What you're doing is very important, because we can't just sit back and hope that these drugs that we're throwing at MS patients are going to get them through. And
Exactly.
I think future generations are going to expect more. I really do. Like
You're absolutely right. Meaning, I'm going backwards when I was, 25 years younger, and everything was so mesmerizing, as you're saying. Everything was something because we didn't have anything. I was trained initially in Israel, and at that time it came Copaxone.
yes,
That was before Betaseron, before everything. We were giving
I've been
this
on both of those.
and this Copaxone, we started to use it and give it the so-called an IND for patients all over the world, and having patients from Brazil and so on, that they sold their houses only to come to have this Copaxone and so on. And it was, and before this we didn't have anything, and
Right.
still at that time there was not proven, that this is helpful. And many times at that time I was saying to the first patient I saw that has MS, you have a demyelinating disease. I wouldn't have the courage to say you have MS. So it's so much different, and there is no question that we are much better after so on, but I expect much more too.
Right, right. We all do. We're all looking for that magic bullet, for somebody somewhere to get it. And that's the thing. I think we all hope that it's one thing, but as you've said throughout the conversation, it's a combination.
It's also the issue what we're talking about now. It's all the repair and protection, and
Yes,
that's
demyelination.
will be coming more and more. But in the same time, if we don't have so much information in its own protection and repair, we have to start to work on this rehabilitation, uh, measures, and that is only being active, socializing, exercising, and the good health, meaning good diet, meaning it's very, very important. And I'm very concerned when I'm trying to talk to my patient that have fatigue, that really the exercise and so on and very well organized is helpful, instead to look for a pill.
Right.
And it's very important for people to understand how important it is, the rehabilitation for cognitive repair and so on. All this can be done with certain, interaction, exercises,
Yeah.
computer things, and not a pill.
Right. I think a lot of people are just looking for a pill to get rid of the fatigue, a pill to get rid of the spasticity. They want a quick fix. We all want a quick fix, but I'd rather get to the root of what's going on and work from there up. So,
Correct.
but that's good advice. Dr. Weinstock-Guttman, thank you so much.
Thank you for having me.
Good luck with all your future research. And as I said, I've got my eye on you.
Okay.
Thank you so much.
You take care and take care of yourself and keep safe.
Thank you. For more information on the MS Gym, you can find them on Facebook, Instagram, or at themsgym.com. If you'd like to know what I've been up to lately, you can catch me at brookslick.com. We'll see you on the next episode.